I'm Jerad Gardner. I'm an assistant professor of pathology and dermatology at the University of Arkansas for Medical Sciences in Little Rock. And I'm here today with Dr. Philip LeBoit, who is a professor of pathology and dermatology and a dermatopathologist at the University of California, San Francisco. And thanks so much for coming today. And we're going to be discussing your thoughts on melanoma and what the major issues are today, and also lymphoma. So thanks for being with us.
You're very welcome. Thanks for having me.
My first question for you as a junior dermatopathologist is, how do you handle the difficult cases where you're not sure if it's melanoma or not, but it clearly looks worrisome, and also the worry that we always have about getting sued and needing to be defensive. Like, where are we today with that, and how do you handle those kind of cases?
Well, I think, and this is still something that after doing this for 3 decades, I'm still evolving, and
there's no hope for me then.
Yeah, and it's in a way a moving target because you learn from your mistakes and then you try to improve on them. The first thing when conveying uncertainty is to not use the term nevus. I think, like, calling something an atypical nevus in the end is saying, yes, I think it's benign, but it's funny looking, and that doesn't necessarily convey the degree of uncertainty that you might have. So if you're really not sure if something is benign or malignant, it's best to use a neutral term like proliferation. Some people for spitzoid lesions use the term atypical Spitz tumor. That, I think, is a more neutral term. Those are more neutral terms than
because nevus means benign by definition, right? So if you say that and then it behaves badly,
yes,
in hot water.
Yeah, and from a medical legal aspect, you're hot. You're definitely in hot water. At the same time, what you don't want to do is any case that you're uncertain about, just simply call it melanoma, because that's more than you actually know, and it can have a devastating effect on someone's life.
So we have to walk the tightrope in some ways to not lean too far in one direction or the other. You're involved in legal work from time to time, right? And you've seen cases that have gone to court. What are the big issues, the big risks and pitfalls that you see people making in regarding diagnosis or overdiagnosis or underdiagnosis of melanoma?
Well, first I should qualify that by saying that I'm much less involved, and I wouldn't say that I will never ever do a case again, but I do my utmost to avoid being an expert.
I hear that story from a lot of people.
And I've decided that at the beginning I thought that I might play a constructive role, and what I've since learned, unfortunately, is that the way that the system is set up makes it really hard, even with a well-intentioned attorney that you're working with, to actually have a completely dispassionate and truthful argument made in court.
Difficult situation. What kinds of things do you think pathologists should really be aware of to avoid getting themselves into court, not on the expert witness side, but on the defendant side? How do you stay out of trouble?
How do you stay out of trouble?
How am I going to keep out of trouble, Phil?
Yeah. So a number of things. One is to have a tiny little voice in your head that whispers to you when to hold back. And the when to hold back situations are when something is obviously a partial biopsy of a larger lesion, and often you may feel rushed and you may say, "Oh, I'll just call this, a nevus because I have like a lot of cases piling up." But it's best to actually pick up the phone and call dermatologists. I don't like working with dermatologists who aren't willing to talk to me, and I have encountered that. And there are some who say, if I had wanted to tell you, I would have put it on the requisition form.
They didn't want to bias you, right?
Right, or they didn't want to bias you. It's amazing. I think dermatology residencies don't do a really good job of educating dermatologists on how dermatopathologists think and what the world looks like through our eyes. And even our own program at UCSF isn't terribly successful at educating dermatology residents, or at least by the time they get through with training, they don't always they don't always give the clinical information that we've told them for 3 years they should be hearing.
So you find that you get biopsies that are partial of a larger lesion and they haven't told you the size? Is that
Exactly.
a common?
Exactly.
So I see that from time to time as well. It's
Yeah.
hard. It's hard to fix that. What do you just call them? Do you try to put something on the form? Hey, please tell me the size. Have you found any ways that are successful in getting that information ahead of time?
Getting that information ahead of time, I think having a sincere discussion with them about why it's so important is helpful. In terms of on a given case, one thing that I do that I know a lot of dermatologists appreciate is and it's too difficult to call every single time yourself.
Right. Yeah.
So what I do is I have our office staff call the dermatologist's office and say, and give them my cell number and say when it's convenient for the dermatologist in your office, have them call me back. Because when you're calling a dermatologist, they're often in the middle of seeing patients, doing procedures, et cetera. I'm much more interruptible than they are. So so giving them that link, and often that breaks down a lot of barriers. Your willingness to give them, whether it's your direct line or your cell phone line, really helps convey to them that you sincerely want this information. It's really important.
So there's really a lot more to melanoma diagnosis than just understanding histopathology. We have to have communication skills and build rapport to get the information we need sometimes.
Exactly.
Amazing. Let's change gears a little bit. Tell me about sentinel lymph node biopsy, kind of where we are today, and what does it all mean? I often wonder that there are tumor cells there. They're going to dissect the nodes. Are we really helping patients by doing node biopsies? Is there any good evidence that what we're doing is the right thing?
Yeah, so that's a terribly difficult question. I think there's two aspects to it. One is sentinel node technology has told us a lot about the biology of melanocytic lesions. There are things that we never dreamed ended up in lymph nodes that actually do end up in lymph nodes. And I've seen cases that are, if you go back and look at the original biopsy, are unquestionably deep penetrating nevi, or blue nevi, or spitz nevi, and there's nodal involvement. So I think that the idea that benign things never metastasized, which late Dr. Ackerman proposed, just doesn't hold water. At the same time, the question of if you see something in a lymph node, is that grounds for a lymph node dissection? I don't think that the most recent iteration of the MLST study has solved that conclusively. I haven't read that paper as closely as I would like to, but I've looked at it, and there's actually subsets in which people with completion lymphadenectomies do worse, but for some reason that wasn't highlighted in the abstracts or editorials about it. And I was facetious, of course, when I said for some reason.
Yes. It seems like we keep pushing and doing studies and trying to prove the benefit of our current practice, and it seems that the research that's come out haven't been able to fully prove that yet.
Yeah.
It's difficult. So that concept you mentioned about, the benign things can spread, that really kind of bends the mind of many clinicians. How do you get across that concept of it's in a lymph node, but it's probably not melanoma? Do your clinicians, are they comfortable with that? Because mine don't seem to be usually.
No, they're definitely uncomfortable with that, and you really have to spend some time talking to them. And if you think that that's hard for clinicians, it's even harder for patients, and especially for parents of children who've had, say, an atypical Spitz tumor, a sentinel node biopsy showing some nodal involvement, and then they've heard from a surgeon or surgical oncologist basically that unless you have a completion lymphadenectomy, you're going to be murdering your child. And then it's it's very difficult to persuade them that the best thing is to not go any further.
Yeah, that's difficult. Now that I have young children, I can imagine when I see those cases, really disturbing. How do you handle tumors or lesions that are in the Spitz spectrum, Spitz nevus atypical Spitz tumor, spitzoid melanoma. How do you make a decision about which category to put a tumor in, and what kind of treatment do you think is best for those intermediate atypical ones?
I can see you're asking all the easy questions.
I asked the easy ones only,
Yeah,
yes.
okay. So, I started out my intellectual life in dermatopathology, believing in a benign malignant dichotomy pretty strongly, and I've definitely swung to the other side of the spectrum, and I fully believe that there's an intermediate category, for and we really have a poverty of language about this. Like, the Eskimos have 50 kinds of snow, and we start out with two, white snow and black snow, basically. And there's a lot of gray snow, and we're still, I think we're getting better in saying this is gray snow and this is not white snow or black snow, but we still don't know if it's light gray snow or medium gray snow or, medium to high grade snow. And so we're stuck there. But basically, for Spitz nevus, I really like all the criteria to be there. Symmetrical, well circumscribed, et cetera. And I have to say that the recent work on receptor tyrosine kinase gene fusions, I think, is going to alter this a bit, in that we're not just going to say, are the criteria there for Spitz versus melanoma? We're going to be looking at, okay, this is an ALK gene fusion type of Spitz. What are the criteria for that specific lineage that separates Spitz nevus from atypical Spitz tumor from spitzoid melanoma?
So I know a lot of you and your colleagues at UCSF have done a lot of great work in that area with kind of hashing out the molecular underpinnings of these different melanocytic lesions. So do you think going forward there's going to be a larger role for molecular testing and hopefully helping us figure out the behavior and maybe proper treatment of these intermediate types of lesions?
Yeah, for sure. And there's also some feedback the other way. Right now, I would say that I can predict, looking at an H&E slide of a spitzoid lesion with about 80% accuracy, does it have an ALK gene fusion or not?
Wow.
So doing the immunohistochemistry trains you to do the H&E, and we may get to a situation fairly soon, because we have a good antibody to NTRK3. We're working up ROS1. We may get to a situation where we can have a spitzoid lesion, do a panel of 6 antibodies, say what lineage it is, and then work within that lineage to decide whether it's benign or malignant without ever doing the molecular testing.
Amazing.
Yeah.
Coming full circle in
right,
some ways.
Right.
That's incredible.
I mean that is possible. But it's also possible that there may be some things that you can only find out with the molecular testing. And it's probably going to be a situation where, when we started out doing CGH, we were using metaphase chromosomes. And it took 2 months to do, and it was incredibly laborious. And now we're doing arrays. The next generation sequencing is going to provide copy number information that's going to be very, very similar to CGH. And the price of that is going to go down. Right now it's still very expensive.
Sure.
And takes a couple of weeks, but I could easily imagine a situation where it's a few $100s and just takes a couple of days.
When we look back at how much it cost to do the whole genome, and that's 15 years ago, and
Yeah.
here we are now, it's really made a huge decrease over time. Let's talk a little bit about cutaneous lymphomas. You've done a lot of work with cutaneous lymphomas in your career. What kind of issues do you see as the kind of real poignant questions in cutaneous lymphoma today?
Well,
again, the easy questions.
Sure, the easy questions, sure. So there's the questions everybody asks, and then there are the questions that are really important. So the question everybody asks is, how do I make an early diagnosis of mycosis fungoides? And my answer would be, who cares?
Right.
And in the beginning, I thought a real He-Man can make the diagnosis with one lymphocyte in the epidermis, and I should be able to do that. And I realized that that's a really misguided question to ask, because for a clinician, even though the patient may want to have a name for what they have, it's probably better not to give it any name and just treat it.
Sure.
And most of those people will never ever have, severe disease. The real question should be, if you have a patient with patch stage MF, what's going to predict whether they go on to develop plaques and tumors, which is, maybe 10% of the patch stage disease.
The majority will be
patients.
fine long term
Yeah.
and die of something else years down the road, right?
Exactly.
So maybe an early diagnosis is not really helping the patient that much, right? Not really. It's not like an early diagnosis of melanoma where we can really save people's lives. Early diagnosis of mycosis fungoides might not be that important, but just predicting the behavior of that small subset of the bad ones. So do you routinely use immunohistochemistry, molecular, when you have something that's kind of on the early spectrum and the clinician's like, well, it's either chronic eczematous type of dermatitis or it's MF? How far do you work it up? I always wonder,
Yeah.
how many thousands of dollars should I be spending, when I really feel the answer is probably going to come out, I'm not sure in the end.
Yeah. So routinely, I don't do anything but H&E and clinical pathologic correlation. And I find it's very useful sometimes to get the clinical pictures. I had the advantage early in my career of working with Herschel Zackheim, who was a fantastic cutaneous lymphoma clinician. And I used to attend in cutaneous lymphoma clinic. And I feel fairly comfortable getting clinical images of patients with putative patch stage mycosis fungoides and trying to figure out if that's reasonable or not. I have a colleague, Laura Pincus, who has a lot of expertise in cutaneous lymphoma and is also a cutaneous lymphoma clinician. And I think that's far more valuable than immunohistochemistry or molecular biology.
Clinico-pathologic correlation, like in
Yeah.
everywhere in derm path, right? It's so
Yeah.
important.
Yeah.
Do you find that your clinicians make requests for you to perform immunos
Oh,
or
yes.
molecular? Because I feel like I get that, and
Yeah.
I'm always debating, well, I want to make them happy, but I don't want to waste money, and I don't know that it'll help. And it's always a hard balancing act. How do you handle those situations?
Well, there's people that I realize are never going to be persuaded. I don't try to persuade them, and I go out and waste some insurance company's money. On the other hand, I think it's somebody who can be influenced, I try to tell them that this really doesn't help. The cases that are slam dunk mycosis fungoides by H&E will often have aberrant expression of antibodies and will often have a positive gene rearrangement study. And the cases that are really indeterminate are often impossible to figure
Sure.
out by immuno.
What kind of terminology do you utilize for those early kind of where they're clinically thinking of patch stage? There are lymphocytes there, but it's not quite enough for MF. What kind of terminology do you use, and do you add a comment? Well, maybe this could represent MF. Are you defensive in your sign out?
Yeah, well, luckily I don't think MF is something you really have to be defensive about. I've never heard of anybody getting sued for failure to recognize
Great.
mycosis fungoides.
At least there's something less to worry about
at
for
least
me.
there's
That's
something
good.
less. The way that I phrase it is with descriptive diagnoses, things like superficial lymphocytic infiltrate, psoriasis lichenoid pattern, and then a note saying this is a pattern often found in patch stage MF, but the findings are not diagnostic. And what I do, I try to get people to send clinical images or full clinical description, and the best special study is another biopsy.
So kind of serial biopsies
Yeah.
over time to see if there's progression and evolution of the lesions.
Yeah, or even sometimes even people with the same morphology who just biopsying a different area sometimes does a trick. Often people do a punch as their first biopsy, and if on the punch the lymphocytes are all in the epidermis and papillary dermis, that's basically an invitation to shave.
Shave, yeah, get a broader look.
Exactly.
Sure.
Yeah.
Okay, that's great. Now, what about some other types of non-mycosis fungoides lymphoma? What about this small, medium-sized, CD4 positive, pleomorphic? I can't even say the whole name; it's so long. What do you think about that? I still have some doubts about that lesion. I don't really know what it is.
Yeah.
What do you think it is?
Well, I'm very influenced by two people who've thought a lot about this and worked a lot on it. One's Lorenzo Cironi and the other's Ryan Wilhelmsey. And Lorenzo's group did a study of 130-something cases, and they found basically that there were no people who had had disease progression with this. Ryan Wilhelmsey did a study on what he called pseudo T-cell lymphoma, and this was, I think, maybe 15 years ago. And what he's since realized is that the same condition he was calling pseudo T-cell lymphoma, which was often due to a drug back then, is what's currently being called small medium pleomorphic T-cell lymphoma. So I actually signed the cases out as small medium pleomorphic T-cell lymphoproliferative disease. That's not a term that's original with me. Werner Kempf in Zurich made that term up. I haven't persuaded all of my colleagues, even at UCSF, to do that. Some of them still use the lymphoma word. But my guess is that the cases, and there are very few cases that have had widespread disease, those cases are probably something somewhat different.
So maybe there's a bit of a
Yeah.
wastebasket kind of component too, because we haven't really fleshed out there, a group of things maybe that have similar appearance.
Yeah.
So I guess that goes back to your idea with the melanocytic things. If you're uncertain, maybe use a more neutral word rather than lymphoma, when you're not really sure what it is. What about the CD30 positive lymphoproliferative disorders, LYP and ALCL, and then some of the other things like large cell transformation of MF? How do you handle those, and how do you sort them out? Do you sign them out as CD30 positive T cell proliferation and give a differential, or do you try to figure it out by the clinical? How do you approach those?
Yeah, so that's a very interesting question. I've gotten a lot of consultations in the past on those that come with no clinical information.
Nice.
And I think there are some entities that are really quite recognizable, like lymphomatoid papulosis type A.
Yes.
When it's wedge-shaped and there aren't that many CD30 positive cells and there's some neutrophils in the background, and you can actually, make that diagnosis, fairly accurately. But when you get to sheets of CD30 positive cells, as in that look exactly where anaplastic large cell lymphoma, type C LYP, transformation of mycosis fungoides, you really need the clinical to help you. And one of the problems that I see, and I say this with no disrespect to dermatopathologists and pathologists who are working in large labs, is increasingly the model for dermatopathology in the United States is biopsies coming from a clinic where the clinicians are nearly impossible to reach. It may be a dermatologist who's only at that setting for like one day a week, going to a pathologist who has a lot of pressure on him to get the cases out the door. It's easier for that pathologist to take the slide and send it to me than it is to call the clinician and get accurate
But it's the
information.
same problem, just it's in your court now, right?
But it's in my court. So all I
Even
can,
harder to get a hold of the clinician.
Right. So all I can say is it could be one of these three things. But then in the note of the consult, I try to spell out what they should look for. Are these lesions that spontaneously involute? Are these fixed lesions? Has the patient had a full body skin exam? Could they have, an early wrinkly patch somewhere someone hasn't looked? And this can even happen in other settings. I remember very well in cutaneous lymphoma clinic, there was a referral to our clinic for anaplastic large T-cell lymphoma, a patient with a big nodule on the wrist. The residents were about to send the patient out the door, having examined them, and I said, did you look at this patient's buttocks yet? And they said, why should we do that? And I said, well, that's double-clothed skin. This could be transformed MF. That's where to look. And we went back and submitted the patient to the indignity of having their buttocks looked at and found a patch of mycosis
I
fungoides
found that that's
there.
often when I call my clinicians and someone's talking about large cell MF. I said, does the patient have MF in the background? Well, no. I'm like, well, maybe that helps us, figure it out a little more. So, and I think the last thing I'd ask you about is the lesions that I find the most difficult, and I feel like I see these every time I'm on service, are the dense proliferation of small lymphocytes, mostly T cells, some scattered B cells, and it's a little nodule or a little papule clinically. So they're not that concerned. It's a dense infiltrate, but it's not that atypical. Kind of goes back to the small, medium size concept. How do you handle those, pseudo lymphoma versus kind of the indolent types of T-cell lymphoma? How far do you work them up? Do you find molecular helpful? How do you approach cases like that? Because I find those the most frustrating. I never know how far to push things.
That's a terrific question. And I think if you go to the literature, it's almost never addressed.
No.
Because, cutaneous lymphoid hyperplasia, if you look at the literature, is lymphoid follicles. And then you could say, okay, well, we have pseudo T-cell lymphomas. Ryan Willemse described it, or this, small medium pleomorphic thing. But this is something completely different, really, that you're talking about. And I think the vast majority of those cases are benign infiltrates. But I feel on those, at least compelled to do, some at least minimal immunohistochemistry to make sure that I'm not missing something bad. So if it has plasma cells, you do cap and lambda. If it has a fair B cell component, one thing that I've been ambushed by is mantle cell lymphoma going to the skin. Usually that's not heterogeneous, but occasionally you'll see mantle cell lymphomas with some plasmacytoid
That will keep me up at night now. I've never seen one yet, or maybe it's seen me and I just haven't seen it. I don't know.
Yeah. Yeah.
Well, that's one of those things where I always find it kind of challenging. And, I've suspected as well that maybe these are just reactive things, but I can't figure out, why do you think they happen? Do you have any insight or any ideas or theories about it? Because, if I don't see EOs, then I don't think it's probably a bug bite. And, the clinician thinks it looks like a little basal cell or something. And I don't know why this dense infiltration just happens to suddenly show up in the skin.
Yeah.
Do you have any idea what maybe causes them? Or
nope.
That's for future generations to figure out.
That's right.
Very good. Well, thanks for taking the time to talk with us today. It's been great.
Yeah, really enjoyed it.